This is an aesthetic surgery roundtable, and our next section is going to be on implant surveillance. And I think there's been a lot of discussion and a lot of dialogue between plastic surgery and even the FDA about where we've been and where we want to go. So I think, Bill, it may be good to start off and just review what happened at the FDA panel hearing specifically with regard to implant surveillance.
Yeah, absolutely, Jeff. You know, in March of 2019 at the FDA committee meeting, one of the big topics was implant surveillance. And so the recommendation from the expert panel after all the discussion was that really MRI was not working. It wasn't working for patients especially, but it also wasn't great for physicians because the patients just weren't able to do the MRIs. And frankly, there's also some question about how accurate the MRIs actually are. So there was a recommendation that was submitted to the FDA that the use of ultrasound, in-office ultrasound, as a means of implant surveillance should be an alternative that is on the label of breast implants.
Yeah, I think we've all heard a little bit about ultrasound. It certainly seems a lot easier for us and for our patients. I guess the question is its sensitivity and specificity. Brad Bankston has published his work in ASJ. Perhaps, I don't know, Mindy, do you have experience with ultrasound?
Yes, we got an in-office ultrasound in January of 19 and thought that it would be helpful, especially we've got some textured implant patients out there to look for seromas. It has been amazing as a communication tool with patients and to help with anxiety, simply because when we do it in the office, they're looking at the ultrasound with us. And so the amount of communication and education we can do with patients for seromas, if they're textured, for ruptures, for both types of implants, has been amazing.
Great, and I think we've all heard the positive feedback from those of you who have been using ultrasound, but let's take a step back, Pat, and how do we assure that each of us as providers and plastic surgeons have the proper education to be able to do this in our office effectively and efficiently?
Yeah, I'm about the most untechnical. I didn't get the plastic surgeon technical gene that likes all gadgets and things. So I thought, oh, there's not a chance I'll be any good at this. And but I knew it's something we needed to incorporate because our patients weren't getting MRIs, and we weren't able to follow patients with implants to know whether or not they had a silent rupture, especially on our gel implant patients. So I knew that it was something we'd have to do. And I went for like a weekend course, actually, with Brad, and up to his office, and we had like a half a day of kind of theory, which went way over my head. And then they brought in patients, and we ultrasounded the patients. And we bought a system after that, because I thought, well, maybe I could figure this out. We had a day of training for the physicians in our office and for our staff, the nurses, and a couple of our medical assistants. And then after that, I just started every patient that came in with an implant, I ultrasounded them. And especially the ones that I knew weren't ruptured. They were 6 months out from surgery, and I said, do you mind if we just, well, the patients love it. Most of these women have had children, they've had ultrasounds, they love seeing the pictures on it. And in the beginning, I'd see them, and you get an idea of what a normal implant looks like. Then after a while, somebody comes in and is like, okay, wait a minute, this doesn't look absolutely normal. And my nurse would go in on every patient and do the same thing, so she learned how to do it. And then I started, so the first few that I thought, oh my gosh, this patient has a rupture, then I would send them for an MRI. If a patient had 14-year-old implants and they were planning on surgery anyway, we would give them the option. But for a patient that has like a 7, 8-year-old implant that may not have surgery, in the beginning we sent them for an MRI to confirm it. And then we got the best confirmation was in the operating room. I've had one false positive in the beginning. I don't know if I have any false negatives because if we didn't operate on them, but of the ones that I have said were not ruptured and we operated on them, they were not. I've drained seromas. I diagnosed an ALCL case with it, and it doesn't take that long to get comfortable with it, but it takes time. In the beginning, it would take me 10, 15 minutes to scan. Now I can go in there, and you can almost, as soon as you put the probe on, tell whether there's something going on with that implant or not. Especially if, like Mindy said, the textured patients come in and say, no, you do not have a seroma. I mean, it's pretty obvious if they do, and it's so reassuring for them. And you can give them the option, you don't need to have surgery to have your textured implant removed. I'm happy to see, and I tell them, if you want to come in once a month and have us ultrasound you, we'll do that. One of the nurses can do it, one of our medical assistants can do it. We do not charge our patients for ultrasound.
Yeah.
And I think that helps with follow-up too.
You know, the interesting thing is we all grew up in the era, like when we were doing trauma and general surgery, we were in training, we did DPL, right? Nobody does that now. Like plastic surgeons are probably the last specialty to embrace ultrasound technology. You know, general surgery, they all use ultrasounds. OBGYNs use ultrasounds. Breast oncologic surgeons all use ultrasounds. And it's just part of the tools of the way they treat patients. So it's a logical transition for us to start embracing this technology. The technology has actually gotten better. We've had a unit in our office for 9 years. I just got a new unit the first one was actually really good, but the new ones are even better. The transducers are better. I think the way breast implants are now, it actually makes it easier for the plastic surgeon to kind of assimilate the expertise to use the device. But as Pat said, it's not that difficult. And the one thing I would throw out there is that the truth is, I believe that plastic surgeons are better suited to be doing breast ultrasound to look at implants than a radiologist, because radiologists have never even seen an implant. They don't understand what implants are, how they look, how they behave in the body, what are the different things that may affect the ultrasound, whereas it's just natural for a plastic surgeon. So it's actually, I think, quite easy to just gain the experience. And, you know, Brad Bingston and I have, we haven't published this, but we combined our experience in kind of doing ultrasound over the past 5-6 years on patients coming in. And then we typically would have operated on those patients so we know what the ultrasound finding compares to what the actual finding was. And our sensitivity and specificity was about 900 overall patients. It was above 95% for each. And so I think it's a great technology. It's, I think, relatively easy for people to implement, and it goes beyond. Implant surveillance is the big thing, I think, that certainly the FDA talked about. As Pat said, there's other things too, seromas, late seromas, treating those patients. I mean, it's so much easier to just do that in your office, take care of the patient, send the fluid for what you want to send it for. You don't have to rely on some radiologist to get it right. It's much easier for the patient. It's just a win-win.
Yeah, I mean, it sounds so exciting. I guess my question to Mindy and to you, Bill, as leaders of the Aesthetic Society, and certainly Bill with your involvement with education, I mean, are there going to be opportunities for us to learn how to do this? Are there going to be courses that the Aesthetic Society is going to be putting out? Because I think there's a lot of excitement. For someone who has an ultrasound machine in the office but still hasn't necessarily pulled the trigger like you all have, I want to make sure that I am doing it right. So, you know, what can we expect in the future?
Yeah, absolutely. We have actually already done one educational course on ultrasound. It was at the Insights in Breast and Body Contouring meeting last September 2019. But as part of this roundtable is part of a bigger educational initiative of the Aesthetic Society. And that's through an educational grant given to the society by Allergan. But one of the components is ultrasound courses. And so at every meeting that we have, major meetings, we'll be having an ultrasound course. Mindy, I don't know what other comments you might want to make.
Just, I think there's a big need for this. I think members are interested, and I think these courses combined with kind of an overview and then a hands-on experience really allow us to see, hey, this is something we can learn. Much like Pat said, you learn at the course, you go home, you start ultrasounding every implant that you know is normal, and then you start looking at the ones that you're not sure about. It's a great tool, and I think with the courses, we can really help our members to step out and embrace this technology.
Yeah, I think it's really helpful to get patients to come in for follow-up visits. You know, we were all involved in the studies that got the implants reapproved, where patients that got paid to come in for 10 years. Now you don't see patients that often. I've had patients come back now, and I really do. I offer free visits every other year in the beginning, and then after 5 years, I want them to come in every year. And they come in, you say, oh, you look great, everything's fine, go home. Well, here they get something tangible out of it. You know, they get an ultrasound of their implant, and it makes them want to come in. The other thing is for new patients, breast augmentation patients come in, and you talk about, well, the FDA wants you to have an MRI 3 years after it's been put in every other after that, and they're like, who's paying for that? You know, these cosmetic patients aren't. And if you can say, well, you know, I offer high resolution ultrasound to my patients free of charge, you know, you can come in. it's a differentiator for you that you care enough about them that you're willing to do this for them. And I'll tell you, they light up when you tell them that. And I think patients come in, and the first thing follow-up patients come in will say, "Are you going to do the ultrasound?" Because they like to see that their implant is okay. I think it's very reassuring for them, I said the textured patients especially.
Does anybody have a comment about, one question I hear a lot from surgeons that are considering this is the kind of the liability risk. What are y'all's thoughts on that?
We have a consent form that says we are only evaluating their implant, and that we are not radiologists, but we are plastic surgeons. We understand implants, that we suggest if they going to make a surgical decision purely on the ultrasound, that we suggest they also get an MRI. Caroline Glicksman, who just got her law degree, actually wrote the initial one, and that's what we've been using now. And I specifically tell the patients, I'm not a radiologist. And they'll say, I had a cyst here at one point. And a lot of times you can see that stuff, but I tell them, I have no idea what's a benign cyst, whatever. The only thing I'm evaluating is your implant.
Yeah, same with us. We have a consent. We say we're only evaluating the implant. But as Pat says, patients are thrilled with this. And this is delegatable. It's been great when I have patients call who are really nervous. They're really worried about a rupture or a seroma or whatever. They can come in immediately and see my nurse, who then gives me the rundown on the ultrasound. And then when I see them, I can hit the high point.
Yeah, this seems really exciting, and I can see how patients would really love this because it's kind of instant feedback and very reassuring, because clearly there's some anxiety surrounding breast implants for some patients. So how would you all recommend, I go to the Aesthetic Society's course. Is it best just to schedule a day and bring in a bunch of implant patients, just knowing that repetition is going to allow you to be the best way to really learn? Or how did you all bring it into your practice? It sounds like you need a little extra time initially for each patient if you are going to be doing it during your initial clinic, but it would seem to me that maybe having a day where you bring in a bunch of patients would be very fruitful.
Yeah, I think no doubt, Jeff, and it is delegatable, but I think the surgeon should really start doing these. And it doesn't, I think the misconception is that it takes a lot of time. This doesn't take any time. It takes maybe 30 seconds. So every breast implant patient that you see, you could just have it there. You can scan their breast. It really, and you'll get a lot of experience and very quickly doing that. So I think, like you said, you could have a day where you schedule at the beginning, but then as you're seeing patients, these things are very portable. It's almost like a laptop computer. They're very high resolution, and it makes it easy for you just to incorporate into your normal patient visit.
Yeah, we did when we first got it, when we had our training, we had a few patients come in, and then a lot of our staff has implants, so they loved it, because then they had, we ultrasounded them. But it doesn't take that long. I mean, it really is not it doesn't take a long time to do, and it's very easy to see if it's normal. And then once you get that, the other advantage I will say is I had a patient come in with no insurance. I had done a breast augmentation with a textured surface implant 6 years earlier, and she had a swollen breast. And I was like, oh my God. So it's Friday afternoon at 4 o'clock when she calls. So I would have lost the weekend, trying to find a radiologist who would do this test on her. She doesn't have any money. How's it going to cost? Who's going to pay for it? What are we going to do with the lab? I ultrasounded her, drew the fluid off. I called the pathologist, sent it in, and by Monday, we had a diagnosis that was benign. So for that patient, I saved her thousands of dollars. I saved myself probably a year's worth of worrying, a whole weekend of not knowing my patient with a swollen breast, was it anything? So I think, and for the patients who do end up having something like ALCL, if you see that patient, instead of spending a week trying to get her in, like Bill said, making sure the labs are done, I diagnosed my own patient with ALCL, aspirate the fluid, send it off. From the time of her first symptom till the diagnosis was made was less than a week. And she had surgery 2 weeks later. She was a stage 1A seroma only. And that's what we owe our patients. And this is one tool that gets us to early diagnosis on these patients. First symptom, you can see them, get them diagnosed. And I think we owe that to our patients.
Yeah, all I would add is, just like Pat said earlier, when you're learning to use this, I know it's sitting in the corner of your office, on your pre-op patients that you're changing out implants, pre-op patients that they're ruptured. We just started scanning every single pre-op patient, and then I make a note on the H&P what I think's going on. and then you get that immediate feedback. And it really helps. And if you have patients you know are ruptured that are out there, bring them in so you can scan the implants and see what it looks like, and then scan everybody in your office.
One last question for you all, since you have so much experience, is, and I won't hold you to it, but where do you think we're going? I mean, how often do you think we really should be using ultrasound to scan our patients and to look at their implants? I mean, we know what the FDA's recommendations are with MRI, but where do you think we're going to wind up with this, or what are you recommending for your patients right now, Bill?
Yeah, the draft labeling that came out from the FDA was every 5 years that they're recommending some sort of surveillance, so an ultrasound every 5 years. I think that's very reasonable. Again, we've talked about it's very easy to do. The other point I was just going to make is that this technology, it's not, there's a lot of technology out there. Plastic surgeons, I think, get a little bit, have some reservations sometimes about new technology because they're going to buy it, spend a lot of money, it's just going to sit in the corner. Right. This is one of those ones, like, we all have technologies that sit in the corner and we regret buying, and there's also technology we bought that we use all the time. We're like, this was one of the best things I ever did. The ultrasound will be the latter for you. It really is highly effective and something that I think as moving forward. And in addition to the surveillance, there's little other things, we haven't even talked about it, but there are people that are using ultrasounds to do blocks, like what's the tap blocks, or you can look at abdominoplasty if is this a seroma or not. You tell in 5 seconds whether it did. And so those are just little ancillary things that you have this technology, and all of a sudden you're like, wow, this has simplified my management of patients.
Rough cost for the device that you guys have? I mean, you don't have to tell us what company you have, but just so.
Yeah, for me, I mean, I think there's just a number of technologies, and I think somewhere, I think some are even subscription based, but I think for actual hardware unit, it's probably somewhere between $10,000 and $30,000 depending on what you get.
And there's smaller units that are less money, like Bill said, maybe $5,000 to $7,000, but you pay a subscription for watching it on your phone. But compared to the money that we spend on machines, this is way less than a hydrofacial machine.
Yeah, and I think as Bill said, I mean, there's other uses for this device. You'll probably be using it in your office every day in some capacity. Well, I think this session has been very informative. Thanks, Mindy, Pat, and Bill for updating us on this exciting future technology.